Hi students, welcome to the next session in oral pathology. We are discussing about the salivary gland tumors, and we have discussed malignant salivary gland tumors, adenocystic and MEC in the previous videos. Okay, so in this video, we will discuss other malignant salivary gland tumors which are important for your exam, NEET exam. One among this is actinic cell carcinoma. Okay, so the first one you may have heard about actinic cell carcinoma. Acidic cell carcinoma, as the name indicates, it arises from your acinar cell. It is a monophasic tumor and it mainly arises from your serous cell. Okay, the serous cells are the cells which are causing this acidic cell carcinoma. Now, if you take some basic terminology, basic facts about acidic cell carcinoma is that it is considered a low-grade tumor, but it is not that low-grade actually. But it is considered. Considered a low grade malignancy, because actinic cell carcinoma doesn't show much high grade transformations, but it can. Okay, so this is a previous concept. So in the previous question papers, in the old question papers, if you work out, you may see this question, that which among the following carcinoma of salivary gland is considered a low grade malignancy? That is actinic cell carcinoma. Okay, and then comes what about the cell? It is the serous cell which is causing this tumor. And how how a serous cell look like? Because we have discussed in the basic class that it is pyramidal in shape with a nucleus, and there will be so many granules in this. What are these granules which we see in actinic cell carcinoma? Okay, what are these granules you see in the serous cell? They are zymogen granules. Zymogen. So the granules you see in granular cell amyloblastoma is lysosome. Granules you see in an oncocytoma is mitochondria, and granules you see in actinic cell carcinoma is zymogen granules. Okay, you can list it out somewhere and you can write. Okay, now what about the architecture? Now you know the cell. Okay, now let's see the architecture. What is the architecture? What about the architecture? What are the different what architecture this actinic cell carcinoma show? Okay, so please remember the four types of presentation. They can either be solid in nature, means completely solid sheets. Then they can be microcystic. Microcystic means small cystic spaces. They can be papillary cystic. Papillary cystic means they can sometimes show papillary projection into the cystic cavity, and they can be follicular. Okay, just like follicles within a thyroid and all. Okay, just like follicular. So they can be either solid, means it can be either in sheets, or small cystic spaces, that is microcystic. They can be papillary cystic, means they can sometimes be cystic and they show papillary projections like this. And sometimes follicles means large rounded follicles. Okay, so these are the different presentation, architectural presentation. Just remember the names, because they can ask you which among the following is not an architectural presentation of actinic cell carcinoma. They may give you tubular, trabecular. Okay, so don't fall into that. So you may have seen basal cell adenoma, they had tubular, trabecular. Okay, in your actinic cell carcinoma, there is no tubular, trabecular. There is solid. So microcystic, papillary cystic, and follicular. Now there is one interesting question here that we have discussed before that about oncocytoma. Now I have a cell with the granules here. Okay, so I have a round cell with the blue nucleus and the granules here. Okay, so and I have another cell here with the blue nucleus and so many granules in this. No, I got two cells here. Now one is oncocytoma. This cell is oncocytoma, and here this is actinic cell carcinoma. Now, how can you differentiate between oncocytoma and actinic cell carcinoma? This is a very favorite question for your NEET examination, and this is based on a just simple concept. If you know the concept, even if they ask you twisted and turn, you can answer this. Oncocytoma, the granules are nothing but what? Granules are your mitochondria. Okay, mitochondria. Here the granules are zymogen granules. Okay, so oncocytoma contains glycogen. Okay, and actinic cell carcinoma contains zymogen, not glycogen. There is no glycogen. Okay, no glycogen in this. Okay, but there is zymogen, there is aldehyde groups. Okay, zymogen, aldehyde groups are all there in this. Okay, aldehyde groups are there. So what happens is that when I do a PTAH stain, I will get a PTH positive here because I have mitochondria there. So if I do a PTH stain here, there is no use. I will not get PTH here because mitochondria is not here. This is zymogen granules. If I do a PAS stain here, it will be positive because there is glycogen. Here also, if I do a PAS stain, it will be positive because I have other, even if there is no glycogen, I have zymogen, I have other aldehyde groups there. Okay, now what about PAS diastase? Okay, if I am doing a PAS diastase, PAS D, you have seen that in our video on oncocytoma, you have seen, I have shown you that how diastase work. Okay, so diastase will dissolve the glycogen, and what about the result here? This is negative, or we say PAS diastase labile. It is labile. But in case of actinic cell carcinoma, there is no point, there is no not having any glycogen. So even if I do a PAS diastase, even if I put PAS diastase, the diastase is not gonna destroy anything. Nothing gonna happen. There is no glycogen there. So if I do the PAS again, what I get, it is positive, or we say PAS diastase resistant. So this is the main difference between actinic cell carcinoma and oncocytoma, is that they are PAS diastase resistant. Actinic cell carcinoma is PAS diastase resistant, while oncocytoma is PAS diastase labile. Okay, please clear this concept. This is a statement based question. Okay, differentiation of actinic cell carcinoma and oncocytoma is done by PAS diastase. Okay, I hope this is clear. Okay, that is about your actinic cell carcinoma, and this is the histological image. They won't ask you any question in the image of actinic cell carcinoma. This will also look like a granular cell, just like your oncocytoma. It will look like, in the first impression, we may feel that this is oncocytoma. Okay, so it doesn't matter. Now I will go to the next tumor. Okay, I have to discuss that is called a polymorphous adenocarcinoma. So polymorphous adenocarcinoma is next tumor, that is polymorphous adenocarcinoma. The low grade, previous term was polymorphous low grade adenocarcinoma, PLAG. There was a term called low grade. Okay, polymorphous low grade. Now that term is not used now. It is removed. The present term is polymorphous adenocarcinoma. Okay. Now what is the specialty of this polymorphous adenocarcinoma is that this carcinoma usually comes in the minor salivary glands. Minor salivary gland is it is an exclusive tumor exclusively in the minor salivary glands, and mostly it comes in the palatal region. Palate region, 65% of the cases it comes in the palatal region. It can come in the upper lip. Okay, and least common in the buccal mucosa. Okay, anyway, it's a tumor, polymorphous adenocarcinoma, that comes in the minor salivary glands. Now what is the peculiarity of this polymorphous adenocarcinoma is that you have biphasic population. Here you can see both your ductal cells and your myoepithelial cells. Okay, the cells will be biphasic. Here you can see your ductal cells and you can see the myoepithelial cells here. Okay, both population can be seen, and the peculiarity is that the architecture, if you see the architecture, just like your adenoid cystic carcinoma, they can also show cribriform pattern. Your Swiss cheese pattern can be also be seen in your polymorphous adenocarcinoma. Then what else pattern was there in your adenoid cystic carcinoma? Your tubular, that was tubular and solid. See, the same pattern of adenoid cystic carcinoma is shown by polymorphous. Okay, the polymorphous adenocarcinoma and adenoid cystic carcinoma both show same architectural pattern. Both are biphasic. Both are biphasic. Both will show cribriform, tubular, and solid pattern. Both will show perineural invasion. PNI is seen. Perineural. See how similar they are. Polymorphous adenocarcinoma and adenoid cystic carcinoma is very similar, looking very similar. But one thing is there, the perineural invasion is seen, but this polymorphous adenocarcinoma will not show perineural spread. A perineural spread is not seen. Perineural invasion can be seen. And there is one interesting thing here. There is a type of pattern you see in polymorphous adenocarcinoma. There's a special pattern you can see in polymorphous adenocarcinoma. You can see that the cells get arranged in a line actually. Okay, cells are arranged in a line. That's a special pattern in polymorphous. Now, have you seen the red Indians? Can you see this picture here? They are red Indians, right? Red Indians. Now, there was the manners of this red Indian, that when they move from one place to another, they will move in a single line. Okay, they will move in a single line. The leader will go in the front. So, all the other soldiers, they will come in a single line. The leader will go in the front and he keep a footstep like this. All the people who come behind will keep the footstep in the footstep of the leader. Okay, so all the one who is coming behind will keep their foot in the footstep of their leader. So what happens when the enemy see these footsteps? They will think that, okay, there is only one person who has walked here, right? There is only one person. There is only one footstep here. So maybe a single person has walked here. So they will puzzle the enemy. The enemy cannot find the strength of their tribe. Okay, that's how they walk from one place to another. So that is called a single file pattern or Indian file pattern. So okay, single file. They move in a single file or Indian file pattern. Okay, can you see that? You can see this, see these people moving in a single line, right? They are moving in a single line. Similarly, you can see the tumor cells are arranged in a line here, right? You can see that. See the tumor cells are arranged in the line. Okay, so in this picture also you can see that the tumor cells will follow a Indian file pattern. Okay, they are looking like they are arranged in a single line, right? So it is called a Indian file pattern or single file pattern. This is shown by your polymorphous adenocarcinoma. Now you may ask, if this much similarity is there, how we will identify plaque versus adenoid cystic carcinoma? Okay, polymorphous adenocarcinoma versus adenoid cystic carcinoma. How can we identify? See, the cellularity itself, the cells itself. In adenoid cystic carcinoma, the cells were deep blue. Okay, blue cells, deep blue nucleus was there with the angular cytoplasm. Okay, it was blue nucleus with the angulated cytoplasm. Sorry, angulated nucleus. Okay, angulated nucleus. But in polymorphous adenocarcinoma, the nucleus is what? Nucleus is optically clear. Okay, just like orphan Annie. Okay, you can see that there is a cell, there is a polygonal cell. They are polygonal cells with a nucleus which have hole in the center, or it's a optically clear nucleus, just like your orphan Annie nucleus. Okay, so but in adenoid cystic carcinoma, the cells will have a dark angulated nucleus like this, very dark nucleus. So this is how we identify polymorphous versus adenoid cystic. Okay, nothing but now last one small tumor I will say, that is your salivary duct carcinoma. Okay, salivary duct carcinoma. Now salivary duct carcinoma, it is, you know that it is a monophasic tumor. It is arising from the ductal cell, salivary ductal cell. Okay, so terminal ductal cell carcinoma, there are other names for this. Now what is the peculiarity of salivary duct carcinoma is that it is a very high grade carcinoma. Okay, and what to learn in this is that there is a particular histological pattern. Just remember this histological pattern. The histological pattern or the architecture. The architecture of salivary duct carcinoma is that they have a Roman bridge architecture. Roman bridge. So Roman bridge architecture or Roman bridge type of pattern is seen in salivary duct carcinoma. And one similarity is that this will show perineural invasion and perineural spread, both. Okay, both perineural spread and perineural invasion is seen just like your adenoid cystic carcinoma. Okay, so this is about your other salivary gland tumors and most of the areas where they ask questions from. Okay, I hope it is clear to you. So we are winding up the malignant salivary gland tumors. So we have seen benign and malignant salivary gland tumors. Most of the lesions were covered. Okay, so I hope it is clear to you. See you in the next video with the next topic. Bye.